Good evening, everyone. So today our OSCE session is going to be conducted by Dr. Mohammed Ashraf. Sir, as you all know, he is head of the department of uh, orthopedic department in LAP Medical College. Over to you, sir.
Yeah, good evening, everybody. My friends out there in Cochin Orthopedic Society, my dear students. I'm sure this is an auspicious day for all of us. You are in the middle of the celebration over there. Balu and Divya contacted me days back. We were in the middle of our PG examinations. Only yesterday we uploaded our mark and everything. Only today I got free. So sorry for the delay in this presentation. As you know, National Board have changed their examination pattern. Now, examiners has got a limited role because morning session is OSCE with clinical scenario, clinical station, video station, surgical orthotics, ward rounds, or OSCE. So you got more chance to score mark. And afternoon session, as you know, there will be clinical scenario directly from New Delhi, the local cases, either physical or scenario again. So examiners got a very limited role to grill candidates. So it's a good chance for all of you to get through. In fact, most of the candidates are getting through in my last appearance as examiner. So all the best. So our first topic is on scenario, clinical scenario. The knee cases are second to hip cases in almost all national board or postgraduate examinations. The difference is that we know hip is a deep-seated joint. So we are depending so many lines, angles, indirect evidences for the diagnosis. Sometimes even examiners can go wrong. Only when you see the X-ray, you realize that condition is totally different. This is just opposite to knee joint scenario where it's purely a subcutaneous joint. Everything is in front of you. If you miss anything, well, that's a grave mistake. In hip, we can forgive so many things. That's why I took a knee joint as a clinical scenario. This 50-year-old obese lady presented with pain, swelling, difficulty in walking, and stiffness of both knee joints. If you get such a case, the questions are usually typical from the examiner's side. You may have to give some points regarding pain, like at what time pain will be more. For example, morning pain, more commonly seen in inflammatory arthritis like rheumatoid. Pain towards evening, typical of a mechanical problem, degenerative arthritis, osteoarthritis. Pain during night cries or night starts, again typical of tubercle infection, probably tuberculous arthritis. Second is the location of pain, again very important. Most of the knee pathology, patient will point towards anterior part of the knee joint because usually patellofemoral joint is a source of pain. In osteoarthritis, usually the deformity is varus, so they may point towards the medial aspect of the knee joint. Sometimes patient may point towards the popliteal region because of the hamstring spasm. If the pain is more proximal, one should be very careful. The pain over the knee may be a referred pain from hip joint. Pain over the back of the thigh, again, it may not be due to knee joint pathology. It may be referred from pain from low back, sciatic pathology, disc pathology, or lumbar spine pathology. Well, thinking that treating the knee for that pain, one may land up in trouble. Even after replacement, patient may continue to have pain. So should be careful regarding the location of pain. Regarding swelling, usually swelling in arthritis is because of effusion or a subluxated joint. We'll come to that later. Limping or gait, abnormal gait, it is not as important as an hip case, but there are situations that produce typical gait like antalgic gait. The antalgic gait in knee joint, one should notice one important point. Usually hip pathology, antalgic gait, patient will use the cane on the opposite side to reduce the lever arm, whereas antalgic gait due to pathology below the hip joint, patient will hold the cane on the same side. It's very important. If this is a knee joint pathology or foot and ankle pathology, the cane is carried on the same side. It's very important. Second type of gait seen in a knee pathology is stiff knee gait. You can get a short-limbed gait when there is a limb-leg discrepancy. And finally, an important case, patient may have a waddling gait, a Trendelenburg gait, because of the shifting of the weight-bearing axis in a varus, extremely varus knee. So these are the points to elaborate in history of presenting complaints. It's very important because the examiner may ask, especially if it's a female patient, could be a case of secondary osteoarthritis due to rheumatoid arthritis. There may be mixed complaints. If it's a primary osteoarthritis, things are very straightforward. So during inspection, so we have to mention muscle wasting. So often missed sometimes during inspection finding. Muscle wasting is an important thing you have to mention first. Few points regarding muscle wasting. In any joint pathology, the proximal muscles are wasted first. Hip joint pathology, look at the gluteae, not the quadriceps. Knee pathology, look at the quadriceps, not the calf muscles at all. So it's the proximal muscles that controls a joint. So that waste first. Second point, the quadriceps wasting, vastus medialis waste fast and profound because of three reasons. One, phylogenetically it is the last muscle to form, so it muscle waste easily and early. Second, it's more bulky, muscular, so wasting is more obvious. Third point, this muscle takes part in the terminal screw home movement of the knee joint. So that terminal joint movement is not taking place, so it's not being used, so it wastes fast. This is often asked in DNB examination. Which muscle wastes fast? What's the reason for that? The reasons for muscle wasting common to any joint pathology is, one is disuse atrophy, second is reflex inhibition because of pain, third is toxic myopathy, especially in tuberculous arthritis, and finally associated neuromuscular disorder like a neuropathy or myopathy. So one should keep all these reasons for muscle wasting whenever you get a joint pathology. During inspection, often one thing candidates forget is to examine the popliteal fossa. If you keep it for the last, you may often forget. So make it a point to inspect the popliteal fossa during inspection itself. Look for hard swellings like osteochondroma, firm swellings like neurofibroma, soft swellings like lipoma, cystic swellings like Baker's cyst or semimembranous bursa, or even cold abscess, or even pulsatile swelling, popliteal aneurysm. There may be a finding of popliteal fossa if a case is kept in national board examination. So should be careful. Difference between Baker's cyst and SMB is Baker's cyst is midline below the joint line. SMB is medial lying obliquely. That's how we differentiate between Baker's cyst and SMB. Another thing often candidates stumble upon is demonstration of fluid in a knee joint pathology, knee joint case. This will be asked invariably, how to demonstrate fluid in knee joint. This is by inspection, this is by palpation by test, this is by transillumination. This is very important. Fluid could be either synovial fluid like effusion, post-traumatic or inflammatory effusion, you can see that, or could be blood, hemarthrosis, or sometimes pigmental bilionodular synovitis, all these thin cannulate or hemophilic arthritis, all these, there may be blood also. So fluid doesn't mean synovial fluid alone. Inspection, one should mention obliteration of medial parapatellar fossa, lateral parapatellar fossa, suprapatellar pouch. This is very important. And finally, you should tell there is a horseshoe-shaped swelling. So most of the examiners would like to hear that word, horseshoe-shaped. Means fluid is inside the joint, because there may be fluid outside the joint like this. Fluid outside the joint has got a definite shape, hemispherical. Prepatellar bursa, infrapatellar bursa, meniscus cyst, all those things will have a definite shape. Whereas fluid inside the joint, as you said, as you see, you can see a horseshoe shape. It's very important. That's how you demonstrate the fluid in inspection. Coming to palpation. There are three ways to demonstrate fluid inside the knee joint. One, demonstration of minimal fluids, maybe 30 to 50 ml, maybe. This is by a stroke test or fluid displacement test, where most often fluid will be collected in the medial parapatellar gutter. So you stroke the fluid from there with your hand, that becomes empty. Then leave it like that. Observe, you can see it's gradually getting filled over a period of a few minutes. Or you can ask the patient to stand up. You can see it's getting filled from below upwards. This is a fluid displacement test or stroke test. There are so many names for that test. This is to demonstrate minimal fluid inside the knee joint. One should know that. The fluid is 50 to 100 ml. The moderate effusion. Then test is patellar tap, where one should know the steps of patellar tap. Examiner will tell you, will ask you to demonstrate the patellar tap. Before demonstrating any test on a patient, you should tell the examiner that I will explain this test to the patient. I will get his consent, then I will touch the patient. It's a part of examination. Don't forget. So tell the patient what I'm going to do. Take his consent. There are prerequisites before doing patellar tap. Knee must be extended. No fixed flexion deformity. Extended knee. One hand above the patella. The idea is to squeeze the fluid from the suprapatellar pouch into the joint proper so that patella floats. The other hand, 3 fingers, classically 3 fingers, vertically down onto the patella, gently push it down. You can hear a tapping sound of patella hitting against the femoral condyle. Leave it, do it once or twice, gently, because it's very painful. Patellar tap. You can get pseudo negative patellar tap if there is an encysted fluid, if there is a synovial hypertrophy preventing patella hitting against the femoral condyle. Very minimal fluids, too much fluids. Sometimes, very rarely, patellar fracture, patellar pathology. It's a condition where you get a false negative patellar tap in spite of presence of fluids. Well, you want to demonstrate huge swelling, huge effusion, maybe more than 100. Then what you can do is the cross fluctuation. Again, one hand above the patella, suprapatellar pouch across the knee. Other hand below the patella, again across the knee joint. The maximum fluid is above the patella, suprapatellar pouch. Push from there. you can get a separate feeling of separation between the index and the thumb joint below. That means there is fluid inside the joint. It is communicating across the joint. Cross fluctuation, positive. With these three tests, one must know in any knee joint pathology. Next is demonstration of synovial thickening. Again, most of the old generation examiners like me will definitely ask the candidate to demonstrate synovial thickening. Knee joint is the one joint with maximum amount of synovium in the body, very voluminous, and much of the synovium is in suprapatellar pouch. So the synovium will be hypertrophied all over the joint, but it can be demonstrated where it is superficial, suprapatellar pouch and medial parapatellar gutter, 2 points. For demonstrating suprapatellar pouch, start from superior pole of patella, keep on rolling your fingers on the femur. About 5 to 7 centimeters, you can get the reflection of the synovial membrane slipping under your tip of the finger. Second position is start from the medial side of the patella, go medially till you get the rolling feeling. Lateral side, it is not easily palpable because it is thickly covered by iliotibial band and tendinous part of vastus lateralis. Hence, it is not, it will be there, it is not palpable. So, these are basics of synovial thickening. Synovium is doughy. It is palpable, rollable, but cannot be displaced. It may show pseudo-fluctuation like a muscle, and it never shows transillumination, negative transillumination. These are the clinical points. Fine. After these things, one should know how to demonstrate instability in sagittal plane. At least one test. One test to demonstrate coronal plane instability. At least one test to demonstrate meniscus pathology. You need not know all the tests, but one basic, very popular, effective, sensitive test you should know. We'll start with LACHMAN test. You should know the steps of LACHMAN test. 10 to 20 degree flexion. Examiner holding the lower end of the thigh with one hand, upper end of the tibia with the other hand. We're not crossing the joint actually. Fine. You try to move the tibia anteriorly. That's how the test is performed. LACHMAN. LACHMAN means it's a passive LACHMAN because there are modifications for LACHMAN. Many modifications are there. LACHMAN means passive LACHMAN because you may get a question in the OSCE also regarding LACHMAN, or one of the tests in the knee instabilities often asked. LACHMAN. LACHMAN is more sensitive, is less painful, position is convenient for the surgeon, for the patient, and in the presence of blood, in the presence of synovial thickening, in the presence of torn collateral, in the presence of doorstopper effect of the meniscus, everything, you can perform a LACHMAN comfortably. Second thing is that if you flex the knee to 90 degree, the anterior structures like a patellar tendon, quadriceps tendon, patella may hold the tibia from coming anteriorly. If you extend the tibia like this, knee like this, then there is no anterior bracing effect of the quadriceps. So this is more sensitive. Second, in a flexed knee, hamstring can push the tibia posteriorly. In an extended knee like this, that effect of hamstring is negated. That's why this is more sensitive than even anterior joint test. So they will ask, examiners will ask, I will ask, how will you assess the endpoint of the LACHMAN or even anterior joint? Hard means this is a classical teaching. There may be difference in opinion, difference teaching, but one should know the classical teaching in basic things. Hard means normal ligament, firm means partial elongated ligament, Soft is complete obstructive, classic teaching. Second point is you have to compare with the opposite side, because orphanoid patient, there may be laxity. So unless you compare with the opposite side, you may miss a positive pivot LACHMAN test. There are many varieties of LACHMAN, but should know, because again, the OSCE sessions is very active, so you may get a question like that. If the patient is obese, very huge thigh, you cannot hold the thighs, impossible. So you can go for a prone LACHMAN test, or you ask the patient to extend the knee, active LACHMAN test. Instead of keeping the thumb on the upper end of tibia, you can keep it on the tibial tuberosity, a trilat modification, or even you can do a sitting LACHMAN where knees flex on your lap and do the patient an active LACHMAN test. These are the modification of LACHMAN test. The good old anterior drawer test. So they will ask, examiners will ask you, where will you sit? You're sitting on the foot of the patient without hurting the patient. You should tell the patient. Yes, the idea is to stabilize the foot and the tibia leg. Second is, where will you keep your fingers? Fingers are kept across the hamstring tendons, medial laterally. Idea is not to hold the hamstring tendon. Idea is not to press the hamstring tendon, to know whether they are relaxed or not. It's very important. Then classical anterior drawer, keeping the thumb on the tibial tuberosity. Very important to know the forward displacement of the tibial tuberosity. But there is a modification where you can keep one thumb across the joint line, so that you can appreciate the tibial movement forward. Fine. You know the false positive in a PCL torn knee. You know false negative in a tense hemarthrosis or a menisci blocking the forward movement. Even a hamstring spasm can lead to a false negative anterior droitis. There are so many modifications, noise, Fegan, weather max, everything. But you should know at the classic way how to do an anterior drawer test. Anterior drawer is less sensitive, but rotary instability, if you rotate internally or externally, it gives additional points regarding the associated injuries. In that way, it is a good test. The pivot shift test, where you try to rotate the tibia, relocate the tibia, looking at the Geddes tubercle, which is the pivot, and the axis is the PCL. Prerequisite is the intact IT band. These three things you should know: Geddes tubercle, intact PCL, and a functioning IT band. It is very sensitive, but patient may resist, so better to do under anesthesia. So here you can see a lot of you can see relaxed hamstrings. The tibia is moving forward. The surgeon is sitting on the foot of the patient. Yes, moving forward. The classical anterior drawer test. You can see. Yeah, tibia is dislocating, relocating. Relocating. Fine. That's how you demonstrate pivot shift test. So valgus internal rotation. Just remember this acronym, VALIR. Pivot shift, VALIR. Valgus internal rotation, VALIR. You have to check the meniscus also. The gold standard is McMurray test, starting from extension, going into flexion. So often candidates will start from flexion, they'll end up in extension. It's not like that. Extension to flexion. Medial rotation, external rotation for medial meniscus, internal rotation for lateral meniscus. But negative test doesn't rule out a meniscus tear. And a click is more significant than pain. Again, OSCE question. Should be relaxed. Tell the patient what they're going to do. From extension, go to flexion, rotating the leg externally. Patient will point towards the medial joint line. We can hear a click in medial aspect. You can keep your hand on the middle side also, no harm. Rotate internally, flex the knee, flex the knee. You can get a click from the joint. Even if you keep it in the middle side also, you can get a click. Or patient will tell you the pain over the lateral aspect. So that's the McMurray for menisci. Yes, one should check MCL in 0 degree and 30 degree. And I have often seen the candidates holding the limb 30 degree, trying to do a valgus stress test. This is painful for the patient, may produce muscle spasm. So always keep the limb on a pillow, a 30 degree flex position, then do the valgus or varus stress. This is more comfortable for you and for the patient, and will definitely give a positive result. This 30 degree means pure collateral ligament. 0 degree means a combined collateral plus other structures. Very important, especially cruciates. Varus again, same thing. Another thing is measurement. Coming to the measurement in a knee case, so you have to take measurement for the wasting of the muscle at 0, at 5, at 15 centimeter from the joint line above to know the quadriceps wasting. Then always draw the plumb line and the mechanical axis of the lower limb. This is very important because the measurement of intermalleolar distance will tell you regarding the genu valgum, 8 to 10 centimeters, more than that, it's pathological. Measurement of intercondylar distance will tell you about genu varum, 3 to 4 centimeters, more than that, it's always pathological. But problem comes when there's a Windsor deformity. One side varus, one side valgus. You take the measurement, IMD, normal, ICD, normal. There comes the problem. Then how will you assess the coronal deformity? There comes the importance of mechanical axis of the lower limb and plumb line. We know the Fujisawa point. We know mechanical axis deviation. So all those things are important in a combined deformity. There, instead of line just touching the medial malleolus will be far away from the line. Means it's valgus deformity. Medial malleolus crosses the line, means it's a varus deformity. That's how you assess coronal plane deformity in a bilateral knee or a unilateral pathology. Bilateral means a cross bilateral. One side valgus, one side varus, Windsor deformity, or a unilateral knee. We don't know. IMD is 15 centimeter, but we don't know whether it's a right side or left side. There comes the importance of these linear measurements. Of course, you have to measure the rotation also. Will come later. All of you must be knowing all these things. The normal alignment of physiological alignment of the joints. But one thing you should keep in mind: unilateral deformity always pathological. Unilateral deformity, varus, valgus, anything. Progressive deformity always pathological. Painful deformity always pathological. Deformity, the restriction of movement, may be pathological. So these things cannot be taken as physiological. That's very important. When you get a knee joint case or any lower limb case, whether hip joint, knee joint, ankle joint, often this part is forgotten by the candidates. The rotational profile of Staheli is very important. You have to assess rotations at the neck by Craig-Ryder method, at the femur, tibia, by thigh-foot angle, by angle, transmalleolar axis, and foot bisector. This is very important. This will tell you where is the rotation: neck, shaft, angle, or foot. This is often forgotten by the candidates in the examination. This is how you assess the tibial torsion by a thigh foot angle, and assess the foot progression angle. Rotation is the foot in toeing gait or out toeing gait. We don't know whether the femur, tibia, ankle or foot is rotated. This is how you check the rotation of the foot. Normal bisector passes either through the second toe, between second or third toe. It's a valgus. It's mild, moderate, severe valgus bisector. These lines must be drawn in any lower limb case: plumb line, mechanical axis, anatomical axis. The importance of mechanical anatomical axis, as all of you know, because you people are seeing those things measurement daily during TKR. The difference between the anatomical axis and mechanical axis will decide how much valgus you are giving in a knee joint replacement. If the neck shaft angle is more valgum, the difference is less, means you may have to give a 3-degree valgus tube. If it's a varus, coxa vara, difference is more, you may have to give a 5-degree or even 7-degree valgus cut. This is very important. That's the importance of mechanical axis and the anatomical axis. So these are the, when you get a deformed knee, the two things you should do is, first thing, knee flexion test. Flex the knee, see whether it's from the femur or tibia. If it's a femur, the flexion will mask the deformity. If it is from the tibia, flexion will expose the deformity more. If it is from the knee joint, 50-50. There's an exception for this. In dysplasia, the reason why a flexed knee, the deformity is masked because the posterior part of the femoral condyle will be usually normal, not diseased, because of the Hutter. There's a Wolf law. There is no stress across that. There is no deformity. Except in dysplasia patient, this may not be applicable. Knee flexion test may not be applicable. Second test is cover-up test. Cover the part of tibia to know from which part. If it's from the tibia, do cover-up test. You should know whether it's a proximal third or distal third is pathological. So these two things you should know when you get a coronal deformity of the knee joint: knee flexion test and cover-up test. So this is the third part of the knee joint, is the patellofemoral joint, often forgotten to assess because knee is a tricompartmental joint. The pain may be from the patellofemoral joint, so one has to assess the patella, patellofemoral joint, patellar trachy. This is very important. So palpation of patella will tell you whether it's thickened, abnormal, high lying patella alta, low lying patella baja, skewed patella, bipartite patella. All these things you can assess by palpating, knowing the position of the patella. Normally, normal patellar tracks in a linear fashion. Abnormal tracking is a inverted J sign. Many of the conditions, hip joint pathology, knee joint pathology, will produce patellar maltrachy. So unless you draw the line, you may not be able to see the patellar maltrachy. Patellofemoral joint to be assessed by pushing the patella to one side and palpating the patellar faces for patellar chondromalacia, patellar arthritis. You can grind the patella on the femur, patellar grinding test, Soles test. You can move the patella up and down sideways to know the laxity, especially patellofemoral ligaments retinacula. And a frank dislocation can be tested by apprehension test. Fairbank's apprehension test will be positive in a recurrent dislocation of patella, recurrent instability of patellofemoral joint. A Q angle sometimes may be asked how to draw Q angle. When you draw a Q angle, the patella should be stabilized in the trochlea by 10-degree flexion. If you extend the knee and take the angle, patella may move sideways, it may give a erroneous angle. So always ask the patient to keep in 5 to 10-degree flexion so that patella is stabilized in the trochlea, then take the measurement. Again, there may be a question of the Thessaly's test because the current more sensitive test is the Thessaly's test for meniscus tear. Ask the patient to stand with the flexed knee 5 degrees, 20 degree, rotate internally, externally. At 20 degree, patient gets pain. The positive Thessaly's test, you have to support the patient's hand. The knee joint, one should know how to assess the PCL injury. PLC corner, very important, posterolateral corner, often asked regarding recurvatum axial rotation test, dial test, figure of 4 test. All these things are positive in a PLC corner injury. So these are the common deformities seen in an exam case. Like frame knee is not commonly seen nowadays because there is no point of prolonged immobilization for tuberculosis in the past. Triple deformity, often kept in the examination. Triple deformity. The reason is destruction of the capsule ligaments, posterior subluxation, flexion of the tibia because of the pull of the hamstrings, external rotation because lateral hamstrings biceps is more strong. If you get additional valgus deformity with this triple, it is not quadruple deformity. Again, an extensive tuberculous arthritis. Usually, triple, quadruple. Varus deformity, you know how to assess. Valgus, you know. So flexion deformity is also known as procurvator deformity. Extension deformity is known as recurvator deformity. One side varus, one side valgus, we have just mentioned, very difficult to assess. A Winsor deformity, rickets, polio, all these cases can lead to a deformity. Bizarre deformity in Charcot's joint, a tuberculous, a diabetic patient, neuropathic joint. Always examine the spine if you get a bizarre deformity of Charcot's arthropathy. If the knee joint is broadened, patella is broadened, condyles are broadened, with a female, male, with a repeated history of blood transfusion, always think of hemophilia, miserable malalignment syndrome, multiple deformities. So when you get a deformity of knee, it may not be a primary deformity, it may be a secondary deformity. An apparent, for example, apparent bow legs, in increased anteversion of femur, there may be apparent bow legs. When you rotate the joint internally, it disappears. Again, apparent genu valgum on external rotation disappears. It is a secondary deformity actually. You ask the patient to flex the knee joint. In a normal patient, heel touches ischial tuberosity. In a varus, goes medially, valgus goes laterally. When a genu varum or valgum is associated with recurvatum, external rotation of tibia, other deformities of hip or knee joint, it is known as genu varum valgum complex. Then never make a diagnosis of genu varum alone, valgum alone, unless you examine the hip joint, ankle joint, and foot. There are associated deformities, make a diagnosis of a complex. Again, deformity of joint could be due to extra articular deformities, either a malunited fracture of femur or tibia, or a contracture of muscles or IT band. So one has to assess the contractures by appropriate tests. These tests you should know. Duncan-Ellis test for rectus contracture, habitual dislocation of patella, lateralis contracture, genu recurvatum, intermediate contracture. One must perform a Weber's test in ITB contracture, tripod sign popliteal angle, hamstring contracture, and silver skull test in gastrocnemius contracture. All this may be associated with a knee deformity. So this is part of the knee joint examination. So my dear friends, students, so when you get a case of knee joint, for example, in our case, you must make a diagnosis like this. A complete diagnosis must be there. A bilateral genu varum with effusion, most probably due to primary osteoarthritis. It's very important. You have to include your deformity also in the diagnosis. because osteoarthritis diagnosis, you have to confirm it after taking an X-ray also. So these are the things always mention bilateral or unilateral, primary or secondary, degenerative, inflammatory, infective arthritis with and points like deformity must be very specific: varum, valgum, procurvatum, recurvatum, Winsett, triple, quadruple, with or without diffusion. That makes a complete diagnosis, so that examiners cannot get a chance to keep on asking regarding the diagnosis. Thank you. That's a part of the clinical scenario. I have taken only one aspect. Others maybe might have taught you other things also. Fine. So Balu has asked me to present four OSCE stations. So I have prepared four OSCE with often you get either a 2 marks into 3 or 3 marks into 2 or 1 mark into 6, depending on the matter you have to write. So 1 word, 1 sentence, 1 mark, like that, of course. So they mention the full name of the test. But I am not going to ask you questions. So I will tell. The full name is Thomas Well Leg Flexion Test. Often you'll tell flexion test, FFT test, Thomas test, Thomas Well Leg Flexion Test. 2 prerequisites of the test. 1, the couch must be hard. 2nd, spine must be mobile. These are the 2 absolute prerequisites. Without these 2, you may go wrong in assessing the end result. 3rd, often not answered by the candidates, which muscle can lead to false positive test? It's the iliopsoas. And this deformity is known as false positive Thomas test. When you get a false positive Thomas test, how will you exclude that, rule out that? Just rotate the hip joint. The rotation is painless and free. It is because of the psoas spasm. You can just extend the hip joint. Extension may be complete. Passive extension may be complete. Again, psoas spasm. 2 occasions where deformity cannot be concealed. In a hip pathology, this is an sagittal plane deformity. Deformity is a concealed deformity by the spine. The spine has got a limit to conceal the hip pathology, 20 to 40 degree. If the deformity is FFT is more than 40 or 50 degree, then it will be revealed, and spine cannot conceal that. This is one occasion. Second occasion, when there is a malunited subtrochanteric fracture in flexion, again, it may not be concealed by the spine. These are the 2 occasions where it may not be concealed. Modification bilateral pathology, it's a modified Thomas test. You flex both hips simultaneously, extend 1 by 1. Second modification is a prone Thomas test or Staheli's test. Take the patient over the edge of the table. I couldn't include the photographs because I was busy. Edge of the table in a prone position and extend 1 by 1. These are the modification. Fine. Modification obese patients, or the patient is pregnant or patient with a huge tummy, where even flexion position may be difficult. You cannot keep the patient prone. There you can keep the patient in a lateral position and perform the Thomas test. That's a modification in obese patient. So Thomas Well Leg Flexion Test. Fine. Diagnosis is obvious. A claw hand, a total claw hand, and a partial claw hand. Write 3 components of the deformities. So often candidates will tell hyperextension of the MCP joint. No, make it hyperextension of the MCP joint and flexion of IP joint. Third component is more important, abduction of fingers. This is the third more and most important component, abduction of fingers. Well, you can write many number of situations like combined ulnar median palsy, like brachial plexus Klumpke's paralysis, like syringomyelia, peripheral neuropathy. So many things you can write, but you may have to write 3 clinical situations. Mention 2 differential diagnoses, very important, often. One is Folkman's ischemic contracture. Folkman ischemic contracture, where history will be obvious. You can feel cord-like structure in the forearm. Moreover, joints are flexed in VIC. Wrist will be flexed. MCP joint flexed. IP joints flexed. And Folkman test will be, or sign will be positive because of the fixed length phenomena. Extend the wrist, fingers going for flexion. Flex the wrist, fingers going for extension. Folkman's sign or fixed length phenomenon. Second is Dupuytren's contracture. It commonly affects ring finger, little finger, sometimes middle finger also. Joints are flexed. You can feel a cord-like structure. Skin is adherent to the pad, may be associated with plantar fibromatosis, sometimes penile fibromatosis, Peyronie's disease. What is Wartenberg's sign? Wartenberg's sign is the abnormal abduction of little finger. Abducted little finger. The reason is that you may think abductor digiti minimi is paralyzed, so automatically little finger may go for adduction. But adductors, palmar, adductors, interossea are also paralyzed. But these are the reason. But most important reason is because of the hyperextension of the MCP joint. Extensors are abductors. Flexors are adductors. In a flexion deformity, you get adduction of fingers. In extension deformity, you get abduction. These are secondary action of long flexors, long extensors. Long extensors are secondary abductors. Long flexors are secondary adductors. As explanation, mention one static correction surgery and the rationale. Zangoli's capsuloplasty, where you remove a strip of capsule close to the A1 pulley and close the capsule so that you make the MCP joint flexed, IP joint can be extended. The rationale is Bouvier sign or Bouvier maneuver, where if you flex the MCP joint, IP joint extends. Just the principle of knuckle duster splint. Bouvier principle. Knuckle duster splint, same. Zangoli's capsuloplasty, same. Fine. OSCE 3, pediatric orthopedics. Very easy. Identify the procedure. Percutaneous Achilles tenotomy. Don't do tenotomy alone. Don't write tenotomy. Achilles tenotomy. Percutaneous Achilles tenotomy. Fine. Timing of the procedure. We know when you get a forefoot correction, almost complete correction. By third or fourth Ponseti plaster, equinus is not fully corrected. Then plan for percutaneous tenotomy. That's the timing of the procedure. If you're planning for a bilateral procedure, time interval in bilateral procedure, no time interval. You should do it the same day because the development must be monochronous, simultaneous. If you do one tenotomy today, another tenotomy after 2 or 3 weeks, the development may be lacking in one limb, it may be polychronous. Well, what's the treatment after tenotomy? If the equinus recurrence, again tenotomy. Recurrence after tenotomy, treatment is tenotomy, but at a different level, the level above, never at the same level. Precautions to avoid neurovascular injury, It's very important. There are two methods by which you can do tenotomy. One, without seeing the tendon, do a blind tenotomy. Dangerous. This is a hook out tenotomy where you hook the tendon out with a mosquito forceps, see the tendon, confirm the tendon by moving the angle joint, then do the tenotomy. 1 point. Second, always do tenotomy from medial to lateral to protect the neurovascular bundle. Third, use a round tipped blade rather than a sharp tipped blade. Well, what's the histological basis for plaster changing? Every 10 or 15 days you are changing the plaster. Why? Can you wait for 1 month? No. The collagen will form crimp formation, wave formation after 10 days. Within 7 to 10 days, the structured collagen will produce a wave. Then your correction becomes ineffective. Remove the plaster, stretch it. 10 days, it becomes wavy, stretch it. That's the basis, histological basis of the changing of the cast. Collagen crimp formation. Last OSCE, very easy diagnosis. Define sequestrum. So many definitions are there, but you should tell a precise, effective definition. It's a dead piece of bone inside the living body, usually surrounded by pus or granulation tissue. Sequestrum. Mentioned 5 types of sequestrum. There are many types of sequestrum. Commonest is spindle sequestrum. You can get a tubular sequestrum, diaphyseal osteomyelitis, a ring sequestrum, amputation stump, pin tract infection, a feathery sequestrum, tuberculosis rarely, amorphous sequestrum in Hansen's disease, black sequestrum, fungal osteomyelitis, cork sequestrum, tuberculosis, kissing sequestrum, tuberculosis. So many sequestra are there. At least you should know 3 or 5. Well, you are the surgeon. You're doing sequestrectomy. You should identify sequestrum on the table. One, it's lying loose inside pus or granulation. Second, one side will be rough because of the granulation tissue. One side will maybe smooth because of the bathing in pus. Note will be dull because there is no Haversian canal. Normal bone is resonant on tapping. Next point, you scrap the surface of the bone or sequestrum. There may be a bleeding paprika sign, no paprika sign on sequestrum. And finally, the removed piece should be immersed in saline. If it sinks, sequestrum. If it floats, maybe a normal piece of bone. Right, true contraindications in sequestrectomy. 1, premature or incompletely formed involucrum. In a pediatric age, never do sequestrectomy. You will invite a pathological fracture. Let the involucrum form completely, then remove the sequestrum. Second, partially detached sequestrum. You try to move the sequestrum. If it is not moving, better not remove it. Let it separate, then only move it. Remove it. Well, another question. Why there is no sequestrum in tuberculosis osteomyelitis? Sequestrum can be there in tuberculosis osteomyelitis, as I mentioned, feathery sequestrum. But in tuberculosis, it's a slow process. Unlike bacterial osteomyelitis, where the stripping of periosteum is fast, occlusion of artery by thrombosis is so fast, ischemia is so fast, bone becomes sequestrated within no time. Tuberculosis, there is no such pathologies. By granulation, slowly occluded, slowly necrosed, and whatever sequestrum is formed is eaten by the granulation tissue. So not usually formed, rarely you can get sequestrum in osteomyelitis. Another sequestrum in tuberculosis is a kissing sequestrum in TB spine, kissing sequestrum. Mentioned 2 organisms causing diaphyseal osteomyelitis. One is Salmonella osteomyelitis, often seen in sickle cell anemia. Second is tuberculosis osteomyelitis, especially in pediatric age group. This is very important. In pediatric age group, in tuberculosis, it can produce tubular sequestrum in diaphysis because there is no anastomosis inside the bone in pediatric age group. So since there is no anastomosis, any form of obstruction can lead to sequestrum formation. That's why you can get sequestrum in pediatric diaphyseal tuberculosis. I have sent 2 videos. If possible, can you project that?
Yes, sir. Yes, sir. 1 minute.
Okay, fine. So one area often I have seen a candidate stumbling is gait analysis. Gait analysis.
Sir, which one?
So there are 3 types of.
Sir,
Yeah,
which
this one. Okay, fine, fine. We start with this one. No. So, andalgic gait, short-limbed gait, Tiber gait. These are 3 gaits where often there's a confusion for the candidate, for the examiner. This is a typical andalgic gait. Yes, yes. See, he is moving. The pathology is on the right side. The guy is holding the cane on the left side. This is a typical of andalgic gait due to hip pathology. Yes. Next video. Same guy.
sir?
Yes, yes. Start here. Fine, yes. So right hip pathology is reducing the stance phase. Stance phase is much reduced. Look at his face. Andalgic gait, patient will show some evidence of pain on the face. It's very, very obvious. You can see this is the most important sign in andalgic gait. All that things you can confuse, but patient will show some sign regarding the pain. The third video, yes, yes, yes. Yeah, yes, yes. Typical Tiber gait. Typical Tiber gait. No pain. He's walking fast. Tiber gait. Yes. The Tullenberg gait. Tullenberg sign must be positive. Always think that. And third gait where you get confusion is a short-limbed gait. If you think it's a short-limbed gait, ask the patient to walk on equinus foot. Then he will walk without any problem. Or EMS chapel on that side, shoe raise, he will have reduced limping. So these 2 tests will tell you that's a short-limbed gait. So you can very well know andalgic gait, differentiate from the Tiber gait, from the short-limbed gait. These are the 3 gaits where often you confused in the examination, stumbled upon this problem. Okay, thank you guys. Thank you for the listening. Right. I don't think there will be any question because you people are preparing for when is the examination? When is the examination? Anybody?
31st August, sir.
Fine, very good. So you people are lucky. You will get centers in Kerala, so don't worry. And keep on focusing on OSCE, but that will decide the fate. So OSCEs are usually easy. You can score on OSCE.
Sir, one doubt, sir.
Yes.
Sir, in gait, if patient is walking with a crutch, then should we comment about the gait, sir?
Definitely. Crutch single point, crutch single point, 2 point, 3 point, 4 point, swing through, swing to. So if the crutch walking, you should mention what type of gait is that. Andalgic gait, he's using a cane. So ask the patient whether you can walk without a cane. If he says yes, then only check the gait. That will expose the type of gait.
Thank you, sir.
Welcome.
Thank you, sir. Thank you for taking the session, even though you are busy.
No, I'm not busy now. Divya, how are you? Fine. John is there.
I'm fine, sir.
Okay, fine. Very good. So convey my regards. Okay, thank you. Good night. Can I leave?
Sure, sir. Thank you, sir.
Thank you. Thank you, Dr. Ashraf.
Okay, thank you.
Thank you, sir.
Thank you, Balu.